Fortunately, through the emergency department, we prepare for mass casualty events for all intensive purposes every day of the week. We surge at 2 o'clock in the afternoon with multiple patients from multiple different scenarios. So even though it's not a single event, we surge every day. It's something we do all day long. We triage patients all day based upon acuity, and we try to maintain certain principles. For lack of a better term, we are paid for our preparedness, whether it be one patient or 50 patients, but it's something that we do practice every day. It's just when an event happens, we just get a few more patients at a particular time, but we need to maintain certain principles, which are good triage, the keep it simple kind of approach in terms of the initial assessment of patients, decide who is really sick, focus our resources and energies there, and who what we refer to as the walking wounded, worried well are, and put them somewhere else. And obviously, everybody needs to get seen. Everybody does get seen. In terms of an event that brings multiple patients to the hospital and the types of injuries, truthfully, every event is different. The types of injuries that you can anticipate are different. What we do know, and I've actually published and researched extensively on, my interest has been built around mass casualty events. If you look at terrorist events, mass bombings, what we do know is that, and Boston proved this true, the World Trade Center proved this true, events in other countries proved this true. In terms of what arrives at the hospital, the vast majority of those patients are what we refer to as walking wounded and worried well. Patients who needed to be evaluated, they had relatively minor injuries that needed to be assessed and managed, whether it be with some sutures, whether it be with some irrigation of the wound, updating of tetanus, some inhalation type injuries. The vast majority of people that do arrive fortunately do have minor injuries. The most critically injured or ill obviously require a lot more resources, but those are more the exception than the rule. And the patients who do arrive at the hospital, we also know that the vast majority of them will be treated and released and will survive their injuries. When mass casualty events do occur, there is a process, and those who unfortunately succumb to their injuries never make it to the emergency departments. But injuries can range from minor burns, they can fractures, head injuries, lacerations, smoke inhalation, depending upon the event, and during other types of events such as pepper spray or a mace release, let's say inside of a movie theater. Those are people who have inhalation type complaints, eye irritation. So it's very dependent upon the type of event. The Boston experience, there was most of those patients had needs for vascular surgeons because of the types of injuries they had. After 9/11 in New York City, there was essentially a shortage of ophthalmologists to handle the ocular types of injuries that were associated with that. So it's very dependent upon the event itself. In the world of emergency medicine, we are the temporizing folks who manage these patients. The vast majority of them can be safely and effectively managed in the emergency departments. General principles of wound care, suturing, fracture care, and they don't necessarily need to see the specialist right away. They would potentially need to see the specialist in follow-up. And so the emergency physician will triage those patients and will make that assessment at that time if they need to bring the specialist in to see. But most of this is actually in follow-up care. Obviously, the Boston experience, these were patients who had significant injuries, including amputations. So realistically, the orthopedist and the vascular surgeon were in short supply on that day. But most events, it's really about stabilizing, assessing, and deciding who needs to see somebody right away. Not all injuries need to see a specialist right away or in the immediate sense. Something that cripples the healthcare system. an infectious illness, the healthcare system is stressed at baseline. The emergency departments are crowded. The inpatient units are crowded. Resources and funding and needs don't necessarily match. But something that cripples the healthcare system by making providers sick, as well as something such as Ebola, if there were multiple patients, the ability to manage all those patients because of the amount of resources that they require. The surgical conditions we can correct. Those patients obviously require resources, but they require resources over the first 24, 48 hours. It is the prolonged events that are really the ones that I fear. There is a fatigue factor that goes with health staff, obviously the medical staff. So something that's prolonged is probably the most dangerous or the most feared event.